Hello everyone, welcome back to your lecture on vital signs. In the previous lecture we covered temperature and heart rate, and in this one we will cover respirations, blood pressure, and patient education. So let's start with respirations. What are respirations? Respiration is ventilation, breathing, right? That's breathing. And the exchange of oxygen and carbon dioxide in the lungs through inspiration and expiration. Ventilation is the actual act of breathing. Respiration is the exchange of oxygen and carbon dioxide in the lung through inspiration and expiration. We measure ventilation with the respiratory rate, rhythm, and depth. So this is your actual breathing, right? Breathing in and breathing out. So diffusion, let's talk about diffusion. A few more definitions here. The exchange of oxygen and carbon dioxide in the lungs. Perfusion is the flow of red blood cells to and from the pulmonary capillaries, and we'll discuss this in more detail when we cover the cardiovascular system. What is the normal rate of respirations? It's 12 to 20 breaths per minute. What is the respiratory depth? The respiratory depth is how deeply a person breathes. It can be shallow, it can be deep. The rhythm is the pattern of the breaths and intervals between them. Irregular rhythm means that the person is breathing and then there are pauses between the breaths are unequal. Respiratory patterns, these are the different terms that you should be aware of. It's apnea, eupnea, dyspnea, and orthopnea. What is eupnea? It's normal, non-labored respiration. The relationship of one respiration to 4 heartbeats is fairly consistent in healthy people. So it should be between 12 to 20 per minute. What is apnea? Apnea is periods during which there is no breathing, right? It can be caused by obstructive defect it can be mediated by the central nervous system. Without intervention, death can occur within a few minutes of the onset of apnea. We don't want a patient that's not breathing, right? We want to make sure they're breathing. It's very important. Okay, dyspnea is difficulty or labored breathing. This is what we call shortness of breath, right? It may be a result of heavy exercise or exertion from a health condition, right? It's kind of the feeling you get when you are, say running up a mountain. You feel short of breath, right? That's dyspnea. Orthopnea is when a patient can breathe more easily and most comfortably in an upright position, but experiences shortness of breath when laying flat. And this happens a lot with patients who have COPD, any chronic obstructive pulmonary, obstructive diseases. So they usually prefer to sit straight up. Every time they lay flat, then they start having difficulty breathing. So this is called orthopnea. So what happens is while a person is sitting or standing, gravity lowers the organs in the abdominal cavity away from the diaphragm. And this gives more room for the lungs to expand, to allow, to be able to take in more air with each breath. So it could be, associated with pulmonary edema, heart disease, chronic respiratory diseases such as COPD. These are some important definitions. Please make sure you read them and you include them in your guided notes as you're reviewing this lecture. How do we assess respirations? The nurse should assess respiratory rate. How many breaths per minute? Should be 12 to 20. The depth, are they deep or are they shallow? Right? You have shallow breathing, then you have deep breathing, right? The rhythm, are their breaths regular or irregular? By inspection, observing and listening, or by listening with a stethoscope. Watch the clock used for counting, respirations in seconds. So the pulse oximeter can also be used to assess respiratory effectiveness by determining oxygenation of the blood and monitoring arterial blood gases. This is a non-invasive, indirect measurement of the oxygen saturation of the blood. The expected oxygen saturation should be 95 to 100%. Now in the ICU, some other departments in nursing, in healthcare, we have patients are on automated systems where their respirations are measured. But one important thing to remember is when you're assessing a patient's respirations, don't tell them that you're doing that. Just don't tell them, okay, now just breathe normally because I'm going to count and see how you're breathing. It automatically makes them a little anxious, and so it will affect their respirations. So just, try to assess them without telling them. What are what are the different respiratory patterns? Ineffective breathing patterns cause decreased diffusion of oxygen and decreased perfusion to the tissues. For example, if you're not breathing properly or well or effectively, what happens is that the oxygenation in your lungs gets affected. You're not taking in enough oxygen and you're not putting out enough carbon dioxide. So if the oxygenation gets affected, that same blood that doesn't have enough oxygen goes back to to your heart, and it gets perfused into your tissues. And so the blood that's being perfused or circulated in your body is not going to be oxygenated enough. And you'll understand this a little bit more after we cover the cardiovascular system. So alterations in ventilatory patterns include, first of all, you have your normal pattern, 12 to 20 breaths. Tachypnea. Tachypnea is when you have breaths greater than 24 breaths per minute and shallow. So this can happen because of fever, anxiety, exercise, respiratory disorders. If you notice the pattern there, it shows that they're breathing faster. Then you have bradypnea, where you have your respirations are less than 10 breaths per minute, but they're regular, right? This happens, due to the depression of the respiratory center by medications or from brain damage. Can also cause you to breathe slower. Then you have hyperventilation. You have increased rate and increased depth. And if you look at the pattern here, right here next to the definition, you notice the depth, it's more deeper and it's faster, right? So this happens during extreme exercise, fear, when you're in a very scary situation. DKA, diabetic ketoacidosis, can also cause increased rate and depth. Hypoventilation is when you have a decreased rate and depth of your breathing. This can happen from overdose of narcotics or anesthetics, where your respiration gets really, slow and decreases, and the depth decreases as well, and that can be very dangerous. So it's very important to monitor patients under anesthesia or overdose of narcotics. You see this. Then you have chain strokes respiration. This is alternating periods of deep, rapid breathing followed by periods of apnea, which is no breathing, then back to regular. And if you notice the pattern here, it shows the alternating periods. This can happen from drug overdose, heart failure, increased intracranial pressure, too much pressure in your brain, and renal failure, kidney failure. Then you have BIOTS respirations. You have varying depth and rate of breathing followed by periods of apnea, and they're all irregular. This happens in patients with meningitis and severe brain damage. So these are very important for you to remember. If you notice some of them are in red, these are key terms. Please note them in your guided notes. What factors affect respirations? You have increasing age. The respiratory rate decreases with age, ranging from normal range of 30 to 60 breaths, per minute in a newborn to 12 to 20 breaths per minute in an adult. These are normal, right? But as you age, it decreases with age. Then you have pain. It increases the respiratory rate, but it could decrease the respiratory depth, right? The depth can decrease, but the rate can increase. You're breathing faster, but shallow. Then you have high altitudes. As an adaptation to a higher altitudes, people may exhibit chain strokes respirations, especially when they're sleeping. Higher altitudes increase your respiratory rate and depth prior to adaptation by increasing hemoglobin levels. So what happens when you go to like a place that's high altitude, like in Colorado or a place like that, what happens is that your respiratory rate and depth, before you get adapted, your body takes a while for, a couple of days for your body to get adapted to the environment. Until it's getting adapted, your respiratory rate will increase and the depth will increase. This is your body's attempt to try to get in as much oxygen as it can because there's less oxygen in the air. So it's trying to get in more air in to get more oxygen in, right? And this helps to increase the oxygen levels in your hemoglobin, hemoglobin levels. Then you have anxiety, can cause sighing type respiration, increased depth and increased rate. When you're anxious, you take deeper breaths and you're faster. Exercise increases respiratory rate and depth. Anemia, a decrease in oxygen carrying hemoglobin, it could result in increased rate and respirations. Bronchitis, is a respiratory disease. Any alterations in the normal respiratory structures may result in changes in respiratory rate, depth, and patterns. Most often, it's manifested by difficulty breathing. You're using your accessory muscles, of respiration, such as the intercostal muscles, and increased rate. The depth may be shallower. Now, when you see a patient using the accessory muscles, because usually when you're breathing, to breathe, you use your lungs, right? And your diaphragm are the ones that are involved. But now if you see a person is using like the stomach to breathe or, other muscles of their body to breathe, we call them accessory muscles, then that is that's not a good sign. That means they're having a difficulty breathing, right? Smoking can alter pulmonary airways. This can increase the respiratory rate. Even at rest, even when they're resting. Like, for example, imagine you're running up a mountain again, right? Your respiratory rate is going to increase and you're going to, find it difficult to breathe because it's going really fast, right? But then imagine if that's happening to you when you're laying in your bed watching television. So that's how it feels for people who are smoking. They have, even at rest, their respiratory rate is increased. Then we have medications such as narcotics, sedatives, general anesthetics. They slow the respiratory rate. But drugs such as amphetamines and cocaine increase the rate and the depth of respirations. Acid-base balances. You're going to cover acid-base balances in block 2, but these also result in imbalance, can result in increased rate of depth and respiration, hyperventilation. And if your acid base is not balanced in your body, then it can cause hyperventilation. Brain lesions such as hemorrhages or tumors or damage to the brainstem can cause change in both depth and rate of respirations. Most commonly manifested, as we said, it gets manifested as chain strokes respirations. Once again, this is a video to help you, practice how to assess respirations. I will post this in your Canvas page. Okay, let's move on to blood pressure. Blood pressure. What is blood pressure? It's the force of moving blood against arterial walls. It's measured in millimeters of mercury, mmHg, and recorded as a fraction where the numerator is the systolic blood pressure and the denominator is the diastolic blood pressure. A normal blood pressure of under systolic of 120 and diastolic of 120 with a pulse pressure 40 is normal. Systole. What is the systole? Systole, the top number, is the pressure that arises as the ventricle contracts. Every time the ventricle contracts, with the contraction, you get systole. Diastole happens when the pressure falls as the heart relaxes. So systole means contraction. So anytime your heart contracts, that's the systolic pressure. When it relaxes, that's the diastolic pressure, diastole. So normal range systolic pressure should be less than 120 millimeters of mercury, and diastolic pressure 80 less than 80 millimeters of mercury. What is hypertension? Hypertension is sustained above normal blood pressure. And look at the word here that's used, sustained, right? It stays above normal. The principal determinants of blood pressure are your cardiac output and systemic vascular resistance. And I'll explain this a little bit more in class, but this is basically and we'll cover this when we cover the cardiovascular system. Risk factors. What are the risk factors for increased blood pressure? Obesity, smoking, sedentary lifestyle, stress, the food we eat, and family history. Hypotension, on the other hand, is below normal blood pressure. Then we have a type of hypertension called orthostatic hypotension or postural hypotension. So this is weakness and fainting when standing up. So when a patient changes position, is postural, their blood pressure drops. Systolic pressure is the highest pressure created during ventricular contraction. Diastolic pressure is the lowest pressure present on the arterial walls when the heart rests between the beats during ventricular contraction. Pulse pressure is the difference between systolic and diastolic pressure. For example, 120/80, the pulse pressure would be 40. That's 120 minus 80. That's the difference between systolic and diastolic. Don't confuse this with the pulse deficit, and that's the difference between the apical and the radial pulse. Factors that affect blood pressure. We have age. Older people tend to have increased blood pressure. Remember, the respirations and heart rate in older people decrease, but the blood pressure increases in older people, and that's because of peripheral resistance. And you'll learn more about this again in your cardiovascular lecture. Then we have the circadian rhythm, normal fluctuations during the day. The blood pressure is usually lowest in the morning, and has been noted to rise as much as 5 to 10 by late afternoon, and then falls down again during sleep. Because your body is rested, your heart doesn't need to work that fast, and so your blood pressure is lower when you're sleeping. Food and coffee intake. Blood pressure increases after eating food or drinking caffeinated beverages. Then we have emotional state. Anger, fear, excitement, pain cause the blood pressure to rise, but the pressure falls to normal when the situation passes. Then we have exercise. Systolic pressure rises during periods of exercise and strenuous activity. Medications. Oral contraceptives cause mild increase in blood pressure in a lot of women. That's one example. Now, some medications are given to lower blood pressure, so it will decrease blood pressure. Then we have body positioning. Blood pressure tends to be lower when you're laying flat in a prone or a supine position, but when sitting or standing, when it will be a little higher. Then we have biologic sex. Women usually have lower blood pressure than men until they reach menopause, where their blood pressure increases. Race is a factor in increased blood pressure, right? It's more prevalent and more severe in African American men and women. Weight. Blood pressure is usually higher in people who are obese than in those who are thin. Hypertension. What is hypertension? Is when the blood pressure that is above normal for a sustained period. Systolic blood pressure greater than 130 and diastolic greater than 80. It's considered hypertension is called a silent killer because symptoms are few or none. They're not very noticeable. So this is, according to the American Heart Association, the normal blood pressure less than 120/80, elevated is 120 to 129, but less than 80 on the diastolic. High blood pressure, hypertension stage 1 is 130 to 139, or 80 to 89 diastolic. High blood pressure, hypertension stage 2 is 140 or higher, or 90 or higher. And hypertensive crisis is higher than 180, or higher than 120 diastolic. So what are the risk factors? As we mentioned, African American and Hispanic adults have a higher risk of hypertension, increased blood pressure, increases with age, family history, obstructive sleep apnea can cause high blood pressure as well. Metabolic disorders, type 2 diabetes can lead to hypertension. Obesity can cause hypertension. High cholesterol can cause hypertension. And lifestyle factors. For example, what are some like that sedentary lifestyle, high sodium diet, alcohol use, all of these can cause hypertension. Then we have the treatment. How do we treat hypertension? We treat hypertension by diuretics. Sometimes it could be because they have too much fluid in their body, so the doctors will start them off with the ACE inhibitor or a diuretic or angiotensin receptor blockers, and we'll cover these in more detail and when we study again the cardiovascular system. But these are the medications. And lifestyle changes, weight loss, heart healthy diet, limiting alcohol intake, managing stress, regular physical activity. So when a person goes to the clinic, you check the blood pressure is slightly elevated, the doctor doesn't just label them with hypertension. They encourage them to make lifestyle changes, and then when they come back for a follow-up visit, then they'll check it again. It has to be 2 or 3 sustained readings of elevated blood pressure in order to be diagnosed with hypertension. But lifestyle changes are always encouraged first. Then what are the complications of hypertension? Cardiovascular disease, strokes, heart attacks, heart failure, peripheral vascular disease, abdominal aortic aneurysms. All of these are complications of hypertension. Then we have hypotension, which is below normal blood pressure, less than 90/60 millimeters of mercury. This can be caused by impaired regulation, disease processes such as Parkinson's disease. Pathologic hypotension is vasodilation of the arterioles, where arteries are dilating, and the failure of the heart to function as an effective pump, right? Or loss of blood volume. All of these are pathologic reasons for low blood pressure. Medications can also cause hypotension. For example, antihypertensives, certain antidepressants, anti-anxiety medications, and pain medications can all cause low blood pressure. Hypotension is a concern when symptoms are present. For example, if the patient has a low blood pressure, but they don't have any symptoms, they're usually okay. But if they start getting dizziness, they get tachycardic, they're, pallors, they're syncope, they're fainting, they have increased sweating, blurred vision, nausea, and confusion, then it becomes an emergency. Orthostatic hypotension, what's that? That's postural hypotension. Like we said, when the patient changes positions from laying to sitting or sitting to standing. This is inadequate physiological response to positional changes in the blood pressure. Classic orthostatic hypotension, there's a decrease in systolic blood pressure greater than 20 or a decrease in diastolic of greater than 10 within 3 minutes of standing during a head-up tilt test used at 60 degrees. For example, if they're laying and then you sit them up and their systolic drops more than 20 or the diastolic drops more than 10, that's classic hypotension. Delayed orthostatic hypotension, and we also have initial orthostatic hypotension have different parameters. Please go ahead and read over these. What is the treatment for low blood pressure? Pharmacological interventions. They're given medications to increase their blood pressure. We encourage them to move slowly after resting. If the patient has orthostatic hypotension, when they're waking up after sleeping, tell them to sit on the edge of the bed, dangle their feet a little bit. If they're dizzy, they need to lay back down. If they're not dizzy, then they get up. So slow position changes. And be very careful with ambulating a patient after surgery or prolonged rest, because then when they get up, they can fall. How do we assess hypotension? Let's look at this. Use the following guidelines. So we basically perform hand hygiene, put on PPE if indicated, lower the head of bed, place the bed in a low position, ask the patient to lay flat supine 3 to 10 minutes. At the end of the time, you take the initial blood pressure. Then you help the patient to sit on the side of the bed with legs dangling. After they're sitting on the side of the bed with their legs dangling for 1 to 3 minutes, take the blood pressure and pulse measurements again. Then assist the patient to stand, and after 30 seconds of standing, take the blood pressure and pulse again, and then a second measurement after 60 seconds. You wait for 1 minute and take a third set of measurements, and fourth set after 1 additional minute for 3 minutes. So record these measurements for each position. A decrease in systolic of greater than 30 or diastolic greater than 10 within 3 minutes of standing, when compared with the blood pressure from sitting to supine, shows significant classic orthostatic hypotension. In a patient with hypertension, supine systolic blood pressure of greater than 160, a drop of systolic of at least 30 or more is appropriate. So you're basically checking their blood pressure when they're flat. Then you sit them up on the side of the bed, let them dangle their feet, check their blood pressure again, and then they stand up, and then you check their blood pressure again. And then you compare all three. So if it's greater than a drop of greater than 20 systolic or greater than 10 diastolic, then that is a classic sign of orthostatic hypotension. Assessing blood pressure. The measurement of blood pressure is an important, it's very, important, and we do this as nurses every single day. It's an important vital sign. It identifies the patient's baseline status. It gives you an idea of how their their homeostatic condition, how their blood is circulating, how their heart is working. So identification of changes in the patient's status, it helps us to identify that as well. It's essential for diagnosis and management of hypertension. What equipment do you need to check the blood pressure? You need a stethoscope, a oscillometric device, which is this one right here, Doppler ultrasound device, blood pressure cuffs. Every hospital has different devices. In nursing school, we use the oscillometric device. And we'll practice this in lab. What are the sites for measuring blood pressure? You can do the radial artery site, you can do the brachial artery site, you can do the dorsalis pedis, or the popliteal site. The most common is the brachial. Is most frequently used. What are the methods? You have the auscultatory method. You have an ambulatory blood pressure monitoring method. You have the home blood pressure monitoring system. You have direct electronic blood pressure. You have those, in the ICU we use them. Then you have the oscillometric method of measurement, which we use in nursing school. And we're going to use the two-step method, and I did upload a video in your Canvas page to help you practice that. So in the auscultatory method, the BP cuff is placed on the patient's limb and inflated, causing underlying artery to be occluded and flow to stop. As it gradually deflates, the blood flow is reestablished. Sounds can be heard using a stethoscope placed on the pulse site. So the carotid cough sounds, what are these? These are a series of sounds that correspond to the changes in blood flow through an artery as you're measuring the blood pressure. The auscultatory gap is the period of diminished or absent carotid cough sounds, and it occurs during the manual measurement of blood pressure. So this is the different phases. As you're measuring blood pressure, the first sound heard through the stethoscope, which is the onset phase 1, is carotid cough, represents systolic. The last sound is the diastolic pressure, and auscultatory gap is the period of diminished or absent carotid cough sounds. And we will practice this in Skills Lab, and please review the video that I posted in Canvas, which shows you step by step how to do this as well. Sorry. There you go. Assessing blood pressure, and like I said, I will post a video in Canvas on how to measure blood pressure, and I will also demonstrate it in Skills Lab. Patient education. Remember, as nurses, we're educators. We always educate. Important things to educate with temperature. Body temperature varies during the day. Measure the same way each time. Write down the temperature on a piece of paper so they remember. Clean the thermometer with soap and water, or alcohol. When providing readings to the healthcare provider, mention the method used. Wait 20 to 30 minutes after drinking or eating to check the temperature. These are things that we want to educate our patient about, temperature measurements. What about pulse? Check their pulse before taking certain medications, right? See a watch or a clock with the second hand when taking the pulse. What about blood pressure? We want to encourage them to check it once a week or as the physician instructed. Readings over time are more important than just one reading. Use a validated monitor with an automated inflation cuff. Avoid food, caffeine, tobacco, or alcohol 30 minutes before taking a measurement. Rest 3 to 5 minutes before taking your blood pressure because maybe, for example, they're exercising and then they check it, it's going to show high, right? So you want them to rest 3 to 5 minutes before checking it. Sit comfortably with your back supported and both feet on the floor. Don't cross the legs. It's very important to teach our patients that. Elevate your arm to the heart level on a table or a desk and use the proper size cuff. So once they put on the cuff, they should be able to place 2 fingers, and so it shouldn't be too tight, because if it's too tight, the blood pressure reading shows higher. If it's too loose, it will show lower than what it is. Okay, we're all done with vital signs, and I will see you in class.